Welcome again, everybody. We're back after a short period of interruption due to other commitments. This is a case that has good teaching points for both seniors and juniors alike. So this is a 55-year-old female who presented with left-sided facial pain. Now, I'm sure a lot of you have noticed that the abnormality is seen here on the left. But before we go there, let's take the advantage of looking at the other side and discussing normal anatomy first. First of all, this is a sequence from a brain MRI which is done in a very specific fashion. As you see, CSF is bright, so this is a T2 weighted image. You see that the brightness is extremely white, and this is a heavily weighted T2. And as you'll see as we go through the normal anatomy, that the slice thickness is very small. With the thin slices, you could see more details. So this is a heavily weighted T2 thin slice acquisition, which is also famously called a Fiesta acquisition. For juniors, remember that these are thin slices in T2 that are good for anatomy. And what we're concentrating on here is the posterior fossa of the brain. Here is anterior, this is posterior, this is right, and this is left. And we know the posterior fossa contains the brainstem and the cerebellum. Going from above below, what looks like a Mickey Mouse here is the midbrain. Going lower down, you'll see that you have this component that has a big belly, which is also known as the pons. And as you go further lower down, you have this component here, which is the medulla oblongata. That's for the three brainstem components. Then you have these two big structures here, which are the cerebellar hemispheres. We also know that the cranial nerves arise from the brainstem, and this type of MRI is beautiful for showing most of the cranial nerves that we know about. I will show you a few important ones here. For example, let's concentrate on the right. There is this big cranial nerve here, and this large cranial nerve here is the trigeminal nerve, or cranial nerve number 5. So as we go lower down and looking immediately below the pons, you'll notice this nerve here. So let's follow that here. And this is the 6th cranial nerve, also known as the abducens nerve. Arising from the brainstem, running within the CSF space, are these two big nerves as well. Notice how these two cranial nerves cross the CSF to enter this canal here. This is known as the internal auditory canal. And also note these fluid intensity structures, which represent the cochlea, the vestibule, and the 3 semicircular canals. Anyways, back to the nerves. The more anterior nerve here is the 7th cranial nerve, or the facial nerve. The more posterior nerve that runs within the internal auditory canal is known as the 8th cranial nerve, or the vestibulocochlear nerve. So let's look at this again. This is the 5th cranial nerve. This is the 6th cranial nerve. This is the 7th cranial nerve, and this is the 8th. One final piece of anatomical information is to remember that this is the pons, this is the cerebellum, and this is why this area is called the cerebellopontine angle. Now that we understand all of that, let's go to the abnormality. On the left side, you see this heterogeneous mass. This lesion occupies the cerebellopontine angle and compresses on the brainstem and the cerebellar peduncle here. The lesion also extends into the internal auditory canal, replacing the bright CSF fluid, which widens the internal auditory canal in comparison to the other side. and goes all the way within the canal to touch the cochlea. The two components resemble what's called an ice cream cone appearance. Now remember that the patient presented with left-sided facial pain, and the explanation is seen on this image. Look at the normal right fifth cranial nerve, the trigeminal nerve, and look at the left side here. So the proximal part of the trigeminal nerve on the left side, which runs within the CSF space, is compressed by the abnormality. And this explains why the patient presented with trigeminal neuralgia, since the trigeminal nerve is responsible for sensation of the face. Now, if you look at the abnormal side, you'll notice that you cannot identify the 7th and 8th cranial nerves. Now, this described appearance is so classic for something called vestibular schwannoma. You may have known this lesion by another less accurate name known as acoustic neuroma. So this is a nerve sheath tumor that arises from the vestibular component of the vestibulocochlear nerve, nerve number 8. In many cases, it typically has a component that involves the internal auditory canal, what we call an intracanalicular component. And when both the internal auditory canal and the cerebellopontine angle are involved, it typically gives you this appearance, which we described as an ice cream cone appearance. Although not so clear here, widening of the internal auditory canal may result in what we call a trumpet appearance. It looks like a trumpet. The major differential diagnosis for a soft tissue and enhancing lesion in this area would be a meningioma. Sometimes it's difficult to differentiate between a schwannoma and a meningioma in the cerebellopontine angle. However, 80% of the cases are schwannoma, so schwannomas are more common. If you have an accompanying CT and you see hyperostosis of the bone or calcification within the lesion, that favors a meningioma, which is not the case here. Extension into the internal auditory canal favors a schwannoma, and the presence of an enhancing meningeal component, what we call a dural tail, favors a meningioma, which is also not present here. So this was a case of a large vestibular schwannoma that affects the left fifth cranial nerve, resulting in trigeminal neuralgia. We learned from this case that the Fiesta acquisition is a great way to assess the cranial nerves in the posterior fossa. We also identified the midbrain, pons, medulla, and cerebellum. We learned about the trigeminal nerve, abducens nerve, facial nerve, and vestibulocochlear nerve, which are in order nerves 5, 6, 7, and 8. We learned that the right cerebellopontine angle is an important location for identifying abnormalities such as schwannoma and meningioma. And we saw a classic appearance of a schwannoma resembling an ice cream cone and a trumpet appearance of the internal auditory canal, which is widened. Finally, for seniors, we talked about a bit of differentiating points between schwannoma and meningioma with regards to imaging. By that, I end this case, and I would like to thank you for watching. Your comments are more than appreciated, and see you with more cases later. Welcome again. This is a chest x-ray on an adult female patient. The chest x-ray was performed for a job application, and the patient was asymptomatic. Do you see anything? Let's concentrate on this region here where the finding is present. If you look on the left side, this is the first rib. Compare that to the right where the first rib is here as well. Remember that the first rib goes all the way to insert into the sternum at the costosternal junction. Now that we know that, you have this additional osseous structure here. So this osseous structure is an accessory rib that is not the first rib. This is what you know as a cervical rib. Although this is very basic, it's a very common finding seen in about half to 1% of the population, and it could be unilateral or bilateral. It's mostly asymptomatic. In some cases, it may be symptomatic. A cervical rib, when symptomatic, may compress the brachial plexus, the subclavian artery, or the subclavian vein. And that's what's known clinically as thoracic outlet syndrome. If you don't have a search pattern, even if you're a senior resident, you might miss a cervical rib, which sometimes, as we said, may be important. One of the things that may differentiate between a cervical rib and a normal first rib is the adjacent transverse process. To understand that, let's look here. This is the first thoracic vertebral body. This is the spinous process. And you have these osseous extensions to the side of the vertebral body. These are the transverse processes. Note how the transverse process of the thoracic vertebral body points upwards. And also note how the first rib has a downslope arising from the transverse process. This creates an angle. Now let's go to the vertebral body above T1. This is the seventh cervical vertebral body. You'll notice that C7 has the vertebral body here. This is the spinous process and the transverse process to the side. Now compare the transverse process of C7 with that of T1. You'll notice that it has a different direction. It actually has a downslope compared to the upslope of the transverse process of T1. And that's why when you have a cervical rib, the rib seems to be a continuation of the downslope of the transverse process. So let's summarize what we talked about today quickly. This is a unilateral right-sided cervical rib. Although cervical ribs are relatively common, first, they may be missed. Second, they're typically asymptomatic. The ones that cause symptoms are because of thoracic outlet syndrome by obstruction of the brachial plexus or the subclavian vessels. Knowing the direction of the transverse process of the vertebral body helps you confirm that what you're looking at is a cervical rib or not. The transverse process of the thoracic vertebrae points upwards, and that's why a normal rib creates an angle when it arises from them. That's compared to the transverse process of the cervical vertebrae, which point downwards, which means a cervical rib would have a continuous, smooth downslope from the transverse process without creating an angle. By this, we end this case, which is a good case for juniors and a simple reminder for seniors. Thanks for watching. Your comments are appreciated as usual, and we'll see you with more cases later.